So my name is Friederike Keating. I'm a cardiologist here at Fletcher Allen. I do all kinds of different things. Right now I'm on the inpatient service taking care of folks that get admitted to the hospital with some form of heart problem. I also have a practice where I see folks once a week. I think a lot about cardiac health, and I see a lot of women. I'm one of the only women cardiologists in the state. There's actually only 2 full-time female cardiologists in the state of Vermont, and one other one who's also a cardiologist but who doesn't work in the Department of Cardiology, and you may have had a chance to hear her. She spans the worlds of cardiology and oncology, and that's Dr. Lakosky. So there's only really 3 of us in the state of Vermont, which is nice. Kind of feel very exclusive that way. I was thinking about what we could talk about today, what might be of interest to you. I mean, you already have your, I guess I'll be speaking into the microphone. You have your heads full with health issues today, mostly concerning breast cancer. And here I come wanting to talk about heart health. And I'm impressed that you all have enough mental space left to come into a session that deals with a different health topic. So I applaud you for that. And I was going to just tell you about an initiative of the American Heart Association about how to improve heart health in general. And I'm going to say a few words about screening and about symptoms, and then hopefully have some time for some questions and answers. So the American Heart Association has an initiative that's called the 2020 Initiative to try to improve cardiovascular health. And they start by trying to define what ideal health is. And they say health is the absence of disease, and it's a favorable level of health factors and favorable health behaviors. That's the definition that they start from. Just let you think about that for a minute. And then the next thing I'd like you to do is, it's after lunch. Usually people get a little bit tired after lunch. You've already been at it for a while. And it can also be stressful to hear about health all day long. So what I'd like you to do is just breathe. Close your eyes. And I'd like you to just take a few deep breaths in and out while you're closing your eyes. And breathe in and out. In and out. And keep on going with that. All right, thank you. It's helpful. It kind of centers you sometimes, and I'll tell you about the things that it does to your heart. But I happen to believe that this kind of breathing exercise is actually very heart healthy. And there's a lot of, I'm a scientist at heart. There's a lot of science to back that up. All right, so we'll get back to that toward the end. So again, what is ideal health? Absence of disease, favorable levels of health factors, and favorable health behaviors. I'm going to be talking about some health behaviors in particular. And the reason the American Heart Association focused on health behaviors and health factors is because they figured out that a lot of those can be changed and can be influenced and are under our power to change and to influence. Some of them are not. For example, family history of heart problems is a major, can be a risk factor for folks. So if you have a strong family history of heart attacks, then you're at risk for heart attacks, and of course that's something that's difficult to influence. But there's a lot of factors and behaviors that interact with cardiac health that you can influence. So the 2020 impact goal was stated like this. It's by 2020 to improve the cardiovascular health of all Americans by 20% while reducing deaths from cardiovascular diseases and stroke by 20%. And it rests on the realization that heart disease is a growing problem, it's an important problem, and it's a problem that affects a large percentage of the population. This is a graph that demonstrates to you how the incidence of heart disease deaths and cancer deaths increases with age. So if you look here toward the left, you can see that in young folks less than 45 years of age, there's only 25,000, which is still a considerable amount, but there's only 25,000 deaths in the whole population from cardiovascular disease, and about an even number of deaths from cancer. And then as folks get older, that number increases markedly. And then in middle age, the deaths from cardiovascular disease start, or actually in older age, start exceeding by number the deaths from cancer. And then for very elderly people, cardiovascular disease is more of a, by numbers, more of an issue than cancer. But for a long time, these two things seem to be kind of parallel. The two C's, cardiovascular disease and cancer, kind of go in parallel. If you look at it by gender and age, and you look at the rate of death per 1,000 person years, so that's basically how many people suffer, not death, but disease, cardiovascular disease each year, how many of them are diagnosed with cardiovascular disease each year. And you have here the darker bars are men, the lighter bars are women. And cardiovascular disease is defined as coronary heart disease, heart failure, stroke, or claudication. Claudication means that your legs hurt because of circulatory problems. So those things here are basically the major culprits in cardiovascular disease. And you can see that for each one of these age groups, there are actually more men than women affected. It's called the female advantage. Nobody quite knows why that is. But you can also see what it also means is that women just kind of lag men by 10 years. They do kind of try to catch up as they get older. So while there are fewer women than men that are actually affected by these important cardiovascular diseases, it still is the leading cause of death in women, just as it is for men. Okay. That's something that we've been trying to make people aware of for about 10 years now, and I think that message has sunk in, that heart disease is the #1 killer of women, as it is for men. All right. And again, you can see how much this changes with age. These are maps that demonstrate to you how this looks around the country. There are major differences in the death rates from cardiovascular disease depending on where in the country you are. And we're up here, and generally we're in a relatively lower risk area as far as overall cardiovascular disease is concerned, but not the lowest. The lowest would be the white areas there. And this is coronary heart disease, which is heart attacks. New York doesn't look so good on that one. And this is a death from stroke. There we actually look worse than New York State. And in stroke, as far as death rates from stroke are concerned, women are just as much affected as men. So there they don't have that female advantage. So the rate of stroke is the same in men and in women. So there we're not doing as well as we could. So that's the problem. Now what is the solution? Well, what the American Heart Association has identified, and I find this very useful. I use this when I talk to patients about heart health, is 7 pillars of health, basically, 7 pillars of heart health. 4 of those are health behaviors, and 3 of those are, health metrics, more numbers. So the 4 health behaviors are smoking, weight, appropriate levels of physical activity, and healthy eating patterns, diet. And the metrics are total cholesterol, blood pressure, and diabetes. Okay. All these things interact with each other. You know that weight influences how likely someone is to have diabetes, for example, and diet influences your cholesterol. And both of these things influence your blood pressure. So they're very interrelated. But I think it helps to separate them out because that gives you better targets to go after in your own efforts to modify your health. So I think it's very useful to separate these out. I want to spend some time on weight and physical activity. What I'm not going to talk much about is diet. I think that all of us have pretty strong opinions on diet one way or another, but science changes so much and there's so much other information in this conference, for example, about diet, that I just don't want to go there in this talk. We could spend the whole extra talk talking about diet and what we know and what we don't know about it, and what the recommendations were last year and what they might be next year. Changes all the time. But weight and physical activity I'd like to talk about. So we in medicine generally express weight in terms of body mass index. And an ideal body mass index is less than 25, and poor body mass index is poor. Ideal, intermediate, and poor is how the American Heart Association ranked all these health behaviors. So that's why the wording is the way it is. But poor, or at least unfavorable, is greater than 30. So to bring that in context, it actually goes back to how the body mass index is calculated. You can find that very easily on the web. If you just put in BMI for body mass index into Google, it'll go directly to a link that looks like this. It's from the National Heart, Lung, and Blood Institute. It's a little calculator. You put in your height in feet and inches. You don't have to do centimeters and kilograms. And you put in your weight in pounds, and then it's going to calculate your body mass index, and it'll have the same categories here on the right: underweight, normal weight, overweight, and markedly overweight that I just had in the previous slide. So you don't have to do that right now, and you can't do that right now, and I don't want you to do that right now. Because that's usually not fun for most of us. But just to go back to that for a second, I've been doing a lot of research at the university, and I usually take a bunch of people that I see for one reason or another, and I do some statistics. And every time I take a cardiology population, be it inpatient, be it outpatient, and for whatever I'm looking at them for example, when I look at all the stress tests that are done in our institution, all the nuclear stress tests that are done in our institution specifically, and I kind of try to get some numbers and try to find out some things. Usually one of the things that I always tabulate is the weight. And the average weight of people that come for nuclear stress tests in my hospital is greater than 30, the average. So although Vermont is supposed to be less overweight than other states, actually in my population that I deal with, the average is markedly overweight, or obese as we call it. So that keeps showing up. 31 actually is the average. All right, so that's the weight. Now, here's just a few pieces of advice as far as weight is concerned. I'm looking around the room, and you guys all look pretty good to me. That's because I usually deal with a population that's pretty markedly overweight. But if you do fall into the overweight or very overweight category, the first piece of advice I always have for my patients is don't gain 5 pounds a year, because that's what your body wants you to do for some reason. I think it's evolutionary. We've evolved to kind of hoard food, right? Because we've evolved in times of starvation. So our bodies are designed to hold on to food, and our bodies want us to gain 5 pounds a year. And I know that very well, just like the rest of you do. So don't gain 5 pounds a year. That's already your first battle. If you keep constant, in my eyes, you're already winning. The second one is if you're actually trying to lose weight, it's good to feel hungry. Get used to the sensation of feeling hungry. Only when you feel hungry are you actually losing weight. It's a general rule. There's nothing bad about being hungry, for us. Snacks are questionable. I used to say snacks are evil, but I think that's a little too categorical for some people. For some people that works better than for others. Some people really do like eating a lot of small meals and it works for them. But I think it's unnecessary. The best advice here that I got once, and I learned so much from my patients. One patient was battling her weight year after year, very educated woman, and she would kind of shake her head herself, and she'd say, I just cannot seem to lose weight. And I'd say, well, as long as you're not gaining, you're already winning. And she said, she came one year and she had lost like 20 pounds, which is hard to do and hard to maintain. And I said, what did you do? And she said she went to a behavioral weight loss program here in Burlington. And I said, what did they tell you? And she said, well, they told me not to put things in my mouth all day long. But what that means is, seriously, if you're thinking, you try to go on a diet, you substitute stuff, right? So instead of walking around with a granola bar, you walk around with carrots. You have this bag of carrots that you pull out, Why do you have to put something in your mouth at all? You carry around a bottle of water. I see more people than necessary walking around with bottles of water, trying to fill up their stomach and feel full somehow. And what she taught me is that the first step behaviorally is to get away from that oral obsession that we all have. And I have that too. I love eating. So don't put things in your mouth all day long. It's not necessary. It's just not necessary. Even the drinking part, it's not necessary. All right? And then the final thing is also something I've learned from friends and from patients, which is don't despair and don't judge. There's nothing morally wrong with being overweight. You're not bad people for being overweight. There are a lot of bad people in this world who are perfectly skinny and who are morally questionable. So, and I am someone who has worked on my weight, but I've also got genetic predisposition not to be very heavy. And I've gotten into a position where I've started judging people, oh, he's fat, And something I've had to learn is that it's not a question of character, it doesn't make somebody bad to be overweight. Also, if you're battling serious overweight, it's not something fun to battle because it's a daily battle, and it's almost, you can't really win that battle all that well. There's a few exceptions, like The Biggest Loser, and they get on TV and you know what they do for it, right? But in general, most people will not lose huge amounts of weight and keep it off. So you might as well come to terms, to some extent, into which of these weight categories you fall, and then try not to gain from there. That's already hard. So as a cardiologist, I've come to the point where I don't say, you need to lose 20 pounds, because that's just not how it works. So don't judge, don't despair. I have one woman who comes every 6 months or every year, or how many times I see her, and every time all we talk about is her weight, because that's what she suffers from most, is her overweight. And she cries. Every time she sees me, she cries. And I would like so much to tell her not to give up, but just to come to terms with it, because she's obviously not getting anywhere. And that's okay. You can't make that a center of your life. There's other health behaviors to go after. Physical activity, healthy diet, eating less, being hungry every once in a while. but not obsessing about this one thing. So I've learned not to despair and not to judge. All right, so appropriate levels of physical activity. This is, again, by the American Heart Association. This is where I get a little bit more judgmental and harsher with folks. The ideal physical level of physical activity is 150 minutes a week of moderate or vigorous activity, or 75 minutes of vigorous activity. Now, what does that translate to? 150 minutes translates to 30 minutes on 5 days a week. Okay? And moderate to vigorous means that it's enough to get you a little bit out of breath, which is okay. Vigorous means basically the equivalent of running. And moderate to vigorous is more than just parking the car a little further away and walking. It is really more than just that. Also, this is in addition to your regular physical activity. So if your regular physical activity includes vacuuming, and it includes walking to work, and it includes going across the parking lot, this is in addition to that. The important message, however, is the difference between the intermediate and the poor. So poor level of physical activity is none. An intermediate level of physical activity starts with 1 minute a week. That's good. That means that that first step off the couch is really the most important. And amazingly, there are plenty of people that don't do anything apart from their normal daily physical activity. And again, that doesn't count here. So that 1 extra minute already buys you a whole different class of activity level. And it actually, if you look at statistics of how people do in terms of their health outcomes, that's where you see most of the difference between no physical activity at all and that first level above none. That's where you see the drop in mortality, in death rates from cardiovascular disease. It's most pronounced between none and 1 minute, actually. It's amazing. For those of us who like to take it to an extreme and run every second day and bike up the Bolton Valley Access Road and whatever other crazy stuff my husband does, those things get you this much more, but the most important step is that first step off the couch. So this is shown here, 30 minutes a day for 5 days a week. That gets you up to 150. Or if you are into aerobic activity, 25 minutes at least, 3 days a week. That's how I do it, because I don't like to, I think it's boring to, so I like to just cram it all in. And then, it's also very advantageous to add some strength training to that, especially as you get older, because it's very easy to lose muscle mass as you get older, and it's very hard to gain it back. Muscle mass helps you with a balance as you get older. It helps you, prevent falls, for example, as you get older. So that's where muscle strengthening activity. It says here high intensity muscle strengthening activity. I'd start with some muscle strengthening activity, and I've got some pieces of advice there too. Your body, whether you're underweight, normal weight, or overweight, your body is pretty heavy, and you can use it for strengthening exercises. You don't need any extra tools really for it. If you don't have any hand weights or anything like that, your body provides you with a lot of weight that you can work against, that you can use as hand weights. So if you can't do I'm terrible at doing push-ups, arm strength, upper arm strength. If you can't do push-ups, but you want to exercise your arms, you do push-ups on an incline, like on your stairs, you go like that. If you if you don't want to work with leg weights, you just do squats. You go down and up. That's a lot of weight that you're moving around. Sit-ups, you're using your own body to exercise your belly muscles. So between sit-ups, push-ups, and squats, you've already done a lot of strength exercises. You do that. They recommend here at least 2 days per week. And I'd say do it for 15 minutes. It's also pretty boring stuff, so it's hard to do it any longer. But it's a good thing to do. So my advice here, the first step is the most important. Habits take 6 weeks to form. It's another thing to consider. It's good to be out of breath. There's nothing harmful with being out of breath. That's the only way you increase your aerobic fitness, your cardiovascular fitness, is to get to the point where you get out of breath. And take your time. This take your time thing is something that's specific, that I have, that's my slide for women, okay? This is my slide for the women. That's all of us here. It's really hard for us to find the time. The guys, they go to the gym, right? Even when the kids are little, they find time to go to the gym. They just, a generalization, there's somebody back there raising his eyebrows, but okay, so in general, and from personal experience, I see a lot of men having a better time and an easier time actually making time for their physical activity. And I see a lot of women not making that time. And that's why I'm saying take your time, and I mean take it, take your time. Take those 15 minutes, take those 30 minutes a day to do your thing, and make it your time, take your time. And then make it enough time. 15 minutes if you're really going to run, then do it every day. 15, 25, 30. Remember that first step off the couch. Remember the 6 weeks it takes to form good habits. All right. Now I've talked a lot about lifestyle and general pieces of advice, activity, weight. And you know why? Because it's important to your heart health. It's the most important thing I can tell people. And I see them as an outpatient, and my first question is always, what kind of level of activity do you do? What kind of things do you do in your daily life? I ask every person that. And the reason I do is it's because it's important for heart health. Everything else is next questions. This is how we're doing as a nation with those 7 metrics that the American Heart Association is trying to work on. So if you look at the body mass index, it's about a third, a third, a third. So a third of the group is in the very overweight group, and a third is in the intermediate group, and a third is in the good group. That's how we're doing as a nation. Physical activity, we're doing even worse than the weight. Look, 41% are in the none or poor group. They don't do anything in excess of daily activity, of like activities of daily life. All right? But be honest with yourself. You know, when's the last time you've actually made time to go and exercise? And it doesn't count that you just walk fast with your shopping. And make time for yourself. So it's 40% that don't do any exercise, and that's pretty harsh. All right, diet we weren't going to talk about, and we're not going to look at this. I don't know, but I think their metrics are kind of stern too. And this is what happens to the measurements, to the total cholesterol. Total cholesterol, the things that you can influence with drugs look slightly better. I guess we're making some strides there. Blood pressure, cholesterol, and diabetes, right? But they're still not optimal by any means. And the best one is smoking. I think as a nation there's been a huge amount of progress in terms of smoking. All right, so moving on from the 2020 7 pillars of cardiac health, I just wanted to say a few words about screening for heart disease, and then I think we're going to have some time for questions. Since we are at a breast care conference, at a breast cancer conference, screening is a term associated with cancer, right? Cancer screening. And the answer you're looking for there is a yes or no answer, right? You get a mammogram, you want to know, do you have something or do you not have it? And sometimes you need follow-up tests because, you know, if you do have something on the mammogram, you know that it's not an absolute, so you need the next test. But what you're looking for is a yes or no answer, cancer or no cancer. Unfortunately, with most forms of heart disease, things aren't that absolute. The most common form of heart disease that we deal with is coronary artery disease, the one that leads to heart attacks. And that's mediated by plaque buildup. And here you can see, going from 1 to 6 there, what the progression of coronary artery disease is in a blood vessel. And the one that says number 1 is what we look like when we're under the age of 30 or 20. So that's a smooth artery, smooth lining. 2 is where you start having some yellow in there, some plaque buildup. And that's young adults that start having plaque buildup. So it's kind of a continuous progress. So, there's more and more plaque buildup, and then this is a lot already of plaque. The yellow stuff is like the fatty stuff that kind of builds up in your artery over time. And then this is what a heart attack looks like when that plaque opens up like a pimple bursting. It's really gross, but that's what it is. Opens up and exposes its contents to the blood that goes through the artery, and the blood promptly forms a clot, and then that can lead to a heart attack because there's no more blood coming through the artery when there's a clot in there, right? So that can be a heart attack. And then it heals over, forms a scar, but then there's much less of a hole there, much less for the blood to go through, so the heart can also have lower blood flow, and that can impair the heart's function, and it can also lead to symptoms. So that's the progression of coronary artery disease. And as I said, it starts in young adulthood that you can detect these plaques. So you can see it's not a yes or no thing, right? You won't notice anything, you won't feel anything until you get here. So that's a problem. So how do we screen for something that's not a yes or no thing? And we know everybody has some plaque when they're young adults. The difference between some adults and others that get the heart attack is that some people make plaque faster than others. Yeah, and some people have plaque that leads to heart attacks and some don't. And we know what those plaques look like in the arteries of folks that have the heart attack, but we don't know how to predict who's going to end up here very well. We don't know, we don't have a screening test. What we have is we have indirect measures. For example, we know that people who have a higher cholesterol, they tend to progress more rapidly. People who smoke, people who have high blood pressure, all those things I already talked about. That usually leads to faster progression. So we only have indirect ways of predicting whether somebody's going to get in trouble or not. We don't have any good screening tests. Now you'd say, why don't you just take a picture of my arteries and show me what they look like? Well, even that isn't going to tell you whether you're going to forever be here or whether at one point you're going to get a heart attack. But we do have ways of taking those pictures. For example, there's a CAT scan that can be done of your arteries. A specialized CAT scan that's called a calcium score, relatively low dose radiation, and it can tell you how much calcium you have in your arteries, because what happens to these plaques is they get some calcium on them with time. So you can see whether you have calcium in your arteries or not. And that's a good predictor of whether you're going to get in trouble or not down the road. But it's not a 100% predictor either. It's not like a screening test that tells you, yes, I have a disease that's going to end up in a heart attack or no. It's just about as good as a cholesterol is, unfortunately. But it's a picture, so it's a little more impressive. So I wouldn't mind, when I get older, at some point having a calcium score to see how much calcium I have in my arteries. But again, it's not much better than just getting your cholesterol checked. And with that knowledge, the insurance companies thus far are declining to cover it, because they're saying, well, you're not getting a lot of additional information from it. That might change in the future, so stay tuned. But again, we don't have a good screening test, because it's not a yes or no condition. Okay. We do have a lot of tests to estimate the risk of how fast those plaques are going to build up. And that's the questions about family history, for example, the blood tests, cholesterol that I mentioned, calcium scores, that CT scan that I was talking about. And then we can actually measure the presence of severe blockages, the ones that lead to impaired blood flow around the heart, by doing stress tests. But that's just a snapshot too. It's not going to guarantee you that you're not going to have a heart attack tomorrow. Stress tests are pretty good because people that have pretty normal arteries are generally going to pass their stress test, but it's not a 100% guarantee either. These are all indirect tests. So what do we use all these tests for then? We use tests for people who don't have symptoms but who want to know if they're at risk, and that's generally the tests that go in the direction of cholesterol, blood pressure, weight. And then we use a test in people who have symptoms, like chest pains, and who want to know if they're caused by severe blockages. But in general, only blockages over 70% produce symptoms, and those can be picked up by our stress test. Too much fancy stuff I put in there. Yeah. Goodness gracious. So here's the risk assessment that we generally do with folks who want to know if they're at risk for a heart attack. We do a physical exam, we do a history. We go over their family history, we go over their social history, code word for do you smoke or not? Do you exercise or not? And we go over their symptoms and their activity history, as I already mentioned. We measure their blood pressure, we measure their weight. These things are very, very valuable for predicting. We get a cholesterol level, we get a blood sugar or hemoglobin A1C, those are our diabetes tests. And bingo, we already know all the 7 pillars, except the diet. I haven't put the diet on there. I've got an issue with that diet thing. All right. And then people that have symptoms and want to know if they're caused by severe blockages, we do additional tests. And those are stress testing or CT angiography, which is a CAT scan where we can actually look at the blood vessels, not just at the calcium in the blood vessels. Or if we think that they're threatening a heart attack, we sometimes do a heart catheterization because that permits us to put in stents. That's an invasive test, though. All these things have their drawbacks, and most of them are associated with radiation. So we try to use them with care and caution, and they're not screening tests. All right, symptoms. This, I think, is pretty much almost my last slide, which is a good thing. Typical or atypical symptoms. Here you hear a lot that women don't have very typical heart attack symptoms. It's a myth. All right? It's not true. Everybody can have atypical or typical symptoms. It's about 2/3, 1/3. And yes, for women, it's 60-40. So 60% of women, when you ask them, when they're having a heart attack and you ask them, 60% are going to tell you, yes, I have chest pain or I have arm pain. And 40% are going to tell you, no. So those are the ones with the atypical symptoms. For men, it's 70-30. So 70% have chest pain, 30% don't. So it is a difference, but it's not really a clinically significant difference. So it's not like women are different species or really. The confusing thing here is that as you get older, you're less likely to have typical symptoms. And I told you initially that women get their heart attack 10 years later. So that's why it looks like they have more atypical symptoms. Not because they're women necessarily, but generally because they're older. This has been something that has been studied a lot. There's many, many articles about this. But there's also a lot of misleading information about this. In the end, it's not like women have different symptoms from men categorically. They may be a little bit different, but it's not clinically significant. All right. When to call 911? You should call 911 if you have chest discomfort, chest pressure, chest heaviness, back pressure, something that feels like reflux burning, but that you're not used to, that also makes you feel sick, makes you feel concerned. Then you should call 911. So that's when to call 911. And what women do, and this is not a myth, is they tend to call 911 less than men because they don't think as much about this being a heart issue, or because they rely a lot on social support. So what they're going to do is they're going to pick up the phone, they're going to call their daughter, right? Daughter's going to say, wait, I'll come right over. Daughter's going to drive over, assess the situation, say, Mom, you really should go to the hospital. And then they're going to drive to the hospital. A lot of time wasted here. So, you know, there should be more of a push to pick up the phone a little earlier and call 911. Or if they call their daughter, then the daughter might want to advise the mother to pick up the phone and call 911. Better one time too many than one time too few. All right, so coming back to the breathing, it's just one of my, the things I've learned along the way. When you breathe, you actually influence your nervous system, your parasympathetic and sympathetic nervous system. The sympathetic nervous system is what makes your heart go faster and makes you feel like you're under adrenaline. The parasympathetic nervous system is the opposite, slows the heart down. With each breath you take, And if you know how to take your pulse, you can feel this. Take a deep breath, your heart rate goes up. You breathe out, your heart rate goes down. It's like a little bit of an exercise for the heart. So there's a lot of heart rate variability with each breath, and that's a very healthy thing. The younger you are, the more of this variability you're going to have. As you get older, things get a little less flexible in your arteries, and things get a little less flexible with your nervous system as well. It's a sign of health if your heart rate goes up and down with each breath. It's also something that we try to imitate by giving folks drugs. So a medication we give for heart failure is a beta blocker. A beta blocker suppresses your sympathetic nervous system. It makes your heart less excitable, less reactive to adrenaline. It blocks the receptors for adrenaline. That's what our most effective heart failure medicine does. I've had folks, young women, who didn't want to take beta blockers and who have instead taught themselves to regulate their heart rate with biofeedback and with slow breathing. And that may be just as effective. The studies haven't been done yet, but it's a good way of improving your heart health is to try to control your stress level and do this deep breathing. There's good evidence to support that that's a healthy thing to do. This is just a slide that shows you all the different things that are regulated by sympathetic and parasympathetic nervous system. All your internal organs are, to some extent, under control of those two. And the heart's sitting right there in the middle. Adrenaline versus the opposite. All right? So breathe and take care of yourself. Thank you. Yes?
Any relationship between meditation and heart distress?
It's at the level of belief right now. I believe there is. And I keep looking at the literature to see whether somebody's going to do a study that'll prove it to the scientific community. And I haven't seen it yet. There's one researcher, and this is fascinating. There's one researcher, and I've been trying to find the studies, who's working with heart failure. Again, that's a condition that is actually unfavorably influenced by having too much adrenaline on board. That makes it worse. So what he's found is that this parasympathetic nervous system that kind of slows down the heart can be activated by chanting. Now, don't think I'm totally out here. It's really true. So chants in all religions have something in common, which is that most chants have a certain length. They're usually about 10 beats long, most chants. And if you chant, it's like a long exhale. So it kind of reduces your heart rate right there. And that's why chants increase your parasympathetic activity. Now, what he's done is he's used chanting to see if it influences the progression of heart failure. And there were some preliminary results that were promising, but I haven't seen anything really in our literature pop up yet. But stay tuned. Yes?
I thought I had seen something about from the American Heart Association about meditation.
Yes, they promote that probably for the same reasons. There's also another reason, which is that there is an association between stress and heart attacks, although I didn't mention it because it's much less than it's assumed to be. Stress usually causes heart attacks more indirectly than directly because people that are under a lot of stress tend to eat less healthily, they tend to exercise less. But stress also increases that sympathetic level. So that's where I think the American Heart Association is going with the meditation. Yes?
Can you actually decrease fat buildup in your system through whatever means, the exercise and diet or whatever, or can you get rid of the cholesterol buildup or the plaque buildup you already have?
From what we know, the only way to actually reduce the plaque you already have, the only means that we know is by getting your cholesterol ultra low so that your system actually sucks some of the cholesterol back out of the plaque. And that's very, very difficult to achieve. The only way we know how to achieve that really is with pretty powerful medications. So if you take a statin drug and you dose it really high, then you can sometimes, and then you do ultrasound studies of the arteries, you can sometimes see a slight decrease in plaque, but it's very little. Yes?
They say that chemotherapy and radiation ages your body for 20 years. Does it age your heart also?
Not reliably, not in everybody, and not the same way. Some chemotherapy drugs can be toxic to the heart, and it's usually a dose-dependent effect. For some of them, it's not dose-dependent. So for the doxorubicin, for example, it's dose-dependent. Whereas for the Herceptin, some people get heart failure from it and some don't. But that's not so much like aging. That's more a toxic effect to the muscle itself. Then radiation can lead to a process that's a little more like aging in your arteries. It can make your arteries stiffer. So people that have Hodgkin's lymphoma used to get aggressive radiation to their chest, and some of them developed coronary artery blockages. But from breast cancer radiation, we don't see that so much. Yeah.
If you've always had low cholesterol, are you likely to have less blood?
Are you likely to have less blood? Yes, yes. The amount of cholesterol that you have in your blood kind of influences how much plaque you build. So if you've always had low cholesterol, you tend to have less plaque. Yeah, that's you can see that over all populations, all over the world. That's why we believe that getting your cholesterol down is probably a good idea. Yes?
Is it possible? I'm sorry.
Sorry.
Which?
Do we have a three-way tie there? Or
All right, I'll go.
Okay.
Is it possible if you have a good diet with enough calcium and then you still take calcium supplements that it would be deposited in your blood?
Yeah, there's some conflicting evidence there. The strange thing is that people who have hard water generally have less calcium in their arteries, and I'm not quite sure why that is. On the other hand, supplementing with calcium didn't seem to be necessarily resulting in less calcium in the Women's Health Initiative study, so that didn't work. You know, eating more calcium isn't going to protect you, but eating more calcium doesn't seem to really. There was some recent evidence where eating more calcium was questionable in terms of whether it was good or not for your arteries. It might actually not be good, but there's been conflicting evidence. Words out on that one.
As you get older.
Right.
You know, so.
Yeah. The word is still kind of out on what it does to your heart, is the bottom line. Yes?
But isn't there some evidence that too much calcium affects the aorta?
Yeah, that's the more recent evidence. That's the really recent stuff. But before that, there was a lot of evidence to the contrary. So I'm not sure yet where the truth lies. Yes?
Can you speak to the incidence of what people call a silent heart attack, or is that really a misnomer?
No, it exists. We do have some folks that have silent heart attacks. It's more common there's two scenarios. One of them is people with neuropathies, people who have nervous damage. So for example, from diabetes, they won't feel their chest pain as much. They can just be a little short of breath and it can be a heart attack. Older people can have silent heart attacks where they just don't recall having felt bad at all and come into the hospital and lo and behold, they have a heart attack and they're having totally different symptoms. And also, I think a lot of silent heart attacks are just people kind of ignoring their symptoms and coming to the attention later. And then when you ask them, could it have been that you had a heart attack? They're like, well, there was this one, time where I really felt bad and I had some heaviness and I just lay down and I felt too bad to go to the doctor, so I just kind of slept it out. And that's another form of silent heart attack. Yes?
Can we go back to the question about the chemotherapies and after you finish those treatments like the doxorubicin and Herceptin, over what time frame, months, years, might there still be some cardiac risk?
For the Herceptin, as far as I know, it starts pretty during or pretty close to the treatment. so that your doctor's going to monitor you for that effect by getting regular echoes, for example, usually. For the doxorubicin, it can be later, too. We've had people, after a year or two, have unexpected low heart function. But I think that if it's beyond a year or two, then we question the association, and we're not sure whether it's due to that or something else. Yes?
From your GP to a cardiologist.
What was that?
When do you go, you're being treated correct by your GP? When do you go from a GP to a cardiologist?
So that's a good question. I think if it's just about primary prevention, preventing heart disease, your GP should be good for that. Making a risk assessment, telling you how likely you are to have a heart attack, it's not that hard. There's calculators for that based on these risk factors. I think the time to move to a cardiologist is if you have concerning symptoms, for example, or if there's an issue that your primary care doctor can't handle. For example, you have cholesterol that you've been trying to regulate and you're just running out of options because you can't take this or that drug and you still want to get it down. Or you have blood pressure issue where you just can't get to a point where you're happy with your numbers. That's another point to visit the cardiologist. Or, you can always, go to a cardiologist as a second opinion as well. All right, thank you very much.